Hi, thanks for being here. I'm Anneke Schepman. I work as a policy advisor, as a PhD student, and as a teacher. And I'd like to present here one of my papers of my PhD project. It's about professionals and the role of professionals in collaboration in primary care. But the thing I think that adds to the other presentations, very good presentation by the way, is that my study is more on a sort of different level because it's interorganizational study. So we studied the collaboration between primary care, but sometimes also with hospitals or other like welfare, just as one of the earlier presentations. So the background, interorganizational partnerships, I like to prefer to speak about those interorganizational things. They are increasingly used to tackle complex problems such as multiple morbidity, but also high costs, etc. However, I did systematic literature review and found that most of those collaborations, less than half, they do not generate positive results. So I became to wonder, could it be that professionals are the key to the success of collaboration in the primary care? So this is what my study is about. To what extent does the healthcare professionals' feeling of urgency, involvement, the presence of disadvantages relate to the perceived quality of care according to professionals and the success of the collaboration according to management? So I did the study at two levels, the professional and the management level. I looked especially at that last level because if you ask a professional first about their feeling of urgency and then about the success, it might be a little biased. So that's why I also looked at the management. I did a multi-level analysis, and I explained already that data was structured at two levels. So the level of the professional nested within the level of the project, and the project, that means interviews with project leaders where we asked about the project success. It was a longitudinal study collected in 69 collaboration projects in Dutch primary care. They all started in 2011 and finished about 4 to 5 years later. Data was collected by interviews with the project leader and 2 project employees and among healthcare professionals that delivered care to the patients. And those professionals were not only GPs, but they could also be a nurse or a midwife or like all kind of different professionals. At the professional level, we looked at the feeling of urgency. We measured it by looking at if they felt that there was a need for the project, but also if they could solve a problem. Then we looked at the involvement. So at what level were they involved at the project? So did they were just a member of the project, or did they also have like an involvement in more steering committee or something like that? And we looked at different disadvantages such as that there would be more administration because of the project, or advantages that they were, for example, better, more efficient because of the project. And we scaled it up to a group of disadvantages and a group of advantages. And also we asked about the perceived quality of care before the project and after the project. And then at the project leader level, we just asked about the project success at the end of the study. The results. The study shows that a feeling of urgency for the collaboration project among professionals at T1, so at the beginning and at the end, is of influence of a higher perceived quality of care. The involvement did not show any results, and experiencing many disadvantages has a negative impact on the perceived quality of care. So you would expect it, but it also really worked like that. Professionals that were experiencing many advantages show positive results on the perceived quality of care, also really expected. And these effects were bigger than the effects of the disadvantages. There were no significant outcomes related to the success of the project. So the project success did not relate to any of those, unfortunately, any of those indicators. But the project level explained most of the variance, and that could be an indication that management is important. So that's why I think management level and professional level are both important for the outcomes. That's also confirmed by other research on collaboration. But what we found was that professionals were not as involved as they should be in the projects. They were not aware at the beginning, but also not at the end of the project, that they were even in this collaboration project, which was, well, a bit worrying, I thought. And that might be one of the reasons why literature shows only in less than half of the project success. So my conclusion is the use of collaboration as a strategy to improve care in primary care should be decided by managers, but also by professionals, and there should be a kind of feeling of urgency, so they need to stick to what's the problem, and that should be felt by everyone. But also it's good to look at the advantages and the disadvantages. So what's next? It's one of my papers, but the next one is about the role of the patient. And what about trust in a collaboration? Okay, that's it.
Thank you very much, and it's so important that we try to understand what leads to success in such projects. So did you speak to the managers at all about the level of disengagement by the clinicians?
No, unfortunately not.
Okay. You did. Did you feed back results to them? Or?
Well, we did, but I did not.
Oh, okay. Okay, great.
It's a collaboration of many.
Many people, yeah. Okay. So any questions or comments? Oh, lights back on.
Thank you for the presentation again. Maybe one thing was not very clear to me is the unit of analysis. You spoke about 69 collaboration projects involving GP and nurses, but could you be more clear about what is the management to do with this? It was not very clear to me. Can you say something about the structure of those projects?
Actually, it were projects, were all really different projects. So there could be a collaboration of an organization of GPs with midwives, with nurses. We're really different types of projects that we compare to each other. I don't know if that's really answers your question.
Were they all in individual practices, or were they multiple practice levels of the 69 projects?
There were different organizations within one project. So the 69 projects contained of more than one organization.
Yeah.
That's why I call it inter-organization.
Okay.
Yeah.
Interesting.
Yeah.
Interesting. But it's interesting there was such a common experience amongst very different projects and very different organizations. Yeah.
Yes. Yes.
Yeah. Okay. Yeah. Another question, front here.
Good morning, Adriana Martinez from APTES. You just left an open question that's very interesting to us, which is how to build trust in those relationships. Are you already working on it? If you can share with us a little bit how to build trust relationships?
Well, I've worked on it some ages ago, I think. But yeah, so I can share my paper, but I don't really, I can't really remember it right now.
Do you have anything you could share? Because trust is clearly one of those elements that comes up in any collaboration.
I don't know if this is allowed, but I do recommend you to take a look to the Launza poster, which is displayed here at the Congress. We're trying to work on trust, on high mutual trust between different professionals at the neighborhood level, but some of them are here. But it's really something, because trust, it's a matter of spending quality time together. It takes time. The management has to allow to spend that time. The professional, each professional has to identify that a value of that time, of that invested time, is he or she takes it to his daily or her daily work. So we see it as a craftsman or a craftswoman work, building trust, I mean.
And so you're working on the trust of professionals. And what I do is the management level, the steering committees. That's what I look at.
Yeah, no, that's interesting. So can you talk a bit more about that then? Because one of the things you often find in the management layers is that people move on and get new jobs, whereas perhaps often general practitioners, not always, but often stay in the same area for a long time. But in management, there's more of a culture of you start a project, you leave 2 years later, you get a promotion.
That was one of the problems, yes. but it's a little bit long ago when I worked on this paper.
Okay. Well, that's good. So your poster sounds a very good addition to the discussions today. So that was great. Yes. Yes, great. Question at the back there? Okay. Microphone is coming. It means we build up some anticipation for your question. It's like a dramatic prelude.
You might be disappointed. I'm a GP by background, but Director of Integrated Care at the Health Board in Northern Ireland. So there's a growing trend, in fact it's government policy across the 4 nations of the UK, to encourage GPs to work together in networks. On the basis that GP practices being small units, they may lack time capacity, they may not have the leadership skills to build trust. Have you looked at that, the potential for practices to work together in a network, and then the leadership that emerges from that to work with nurses and other professionals?
Well, we do have data on it, yes, but I haven't really looked at it yet.
Okay. Elizabeth, is that something you touched upon? Because you were looking at primary care, let me remind myself, zones of primary care. Was that something that you touched upon in terms of trust between the different primary care practitioners?
Does it work? Yeah. The trust, I think it's not something you install. It's like we see in our project when the social nurses are present in the GP's practice and they spend time together and they see that what they do it well, that the trust is building itself. So I think we have to learn that it costs time. Because sometimes there are like 6 months in a practice and then they start to work together on a good way. Yeah, I don't think there's a magic word for trust, but it takes time, I think.
Marlene, did you want to add something to that?
Yes, if I may add, I have done a systematic literature review about interprofessional collaboration, and as you know, trust is one major component of collaboration, and what the literature says is that trust is built over time when professionals have had positive previous experiences of collaboration, and when they know that in case of emergencies or any other complex situation, they could rely on each other, which actually send us back to trusting in the other's competencies and the other's intentions also. So, which brings us back to the competition. Are we in competition with one another, or do we trust each other that we have the same objectives related to the patient? So the payment system plays again a major role in this trust when resources are sparse, and when we start to fight on resources, this does not help with trust. So one strategy which is known in the literature, again, I haven't done a field work about it, but it was about interprofessional education. When we learn to know about the other's competencies and the other's specific role. So we trust in these competencies and in the complementary role of the others in relation to the patient care.
Yeah, that's exactly what I meant. Yeah, you have to clarify those roles. So what is the other person doing, and they do it well. And we see that is growing. It's of course easier, I think, when it's perhaps for vulnerable groups and it's a social worker, they know nothing about it, and then certainly the problem is solved, a problem that they know nothing about, and they can do a good guidance of the patient, the GPs then they think, whoa, wow, social nurses are really, they're doing a good job. So yeah, I think what you say is exactly what we have to do. Yeah.
Did you want to add anything from your Northern Ireland experience? Have you lost your microphone? Sorry, yeah.
Well, I mean, I think we've GP federations, so one federation per 100,000 of the population. I think the key thing is that they are owned by the doctors, that they established through their trade union, the British Medical Association. So management can come and go, but you get the consistency of local autonomy, working with management in a collaborative way and working with other professionals. in multidisciplinary primary care teams. So,
Yeah.
I mean, that's going pretty well. In England, you have primary care networks now being introduced in Scotland, GP clusters, and Wales is equivalent too. So, I mean, I do think that's the way to go. I think it gives you organisations a bit like Bertzorg, which has had some successes in nursing and domiciliary care in the Netherlands.
But then one of the key issues is how we ensure that general practice doesn't dominate as a profession, because that's one of the downsides, isn't it? When you've got one profession owning and running the network, there's always a danger that other professions feel, as we heard from some of the other speakers, about the hierarchy and the power dynamics. So that's the next step, isn't it? We've got the general practice engaged, great, but how do we make sure that it's open for collaboration and contribution from others?
Exactly. So in Northern Ireland we have integrated care partnerships, and the federations are a subset of each integrated care partnerships with the other professions, including medical specialists, patients and the third sector included with that. So it means a lot of networks, and that has an overhead, but I think it's well worth it.
And I would encourage anybody who doesn't know integrated care in Northern Ireland to go and talk to our contributor today, because it's often the forgotten part of the UK, but actually it's been doing integrated care for a lot longer than many other parts of the UK. So it's good to hear that flagged up. Great. And one more question over here, and that's our last question, I think. So we're going to finish off in a dramatic finale.
Netherlands.
Okay, great.
Because we have, my name is Mark Bruins, and I'm a director of a small but nice knowledge institute, Jan van Nes Institute, about integrated primary healthcare. And what we see in Holland is now that we have those networks of GPs as well, and the payment reform is going after that. So it's not one of the incentives, but the other way around. But what you see is that especially the GPs are dominating those networks. But now we see in the regions where the GPs have a solid network that the other disciplines start to build their own network as well. And because of that, now you see at the regional level that the interdisciplinary or the interprofessional collaboration starts to work there from those different networks. So we think you should, or I think you should in a way, not want to build everything at the local level, interdisciplinary, etc., organizational wise, because then you end up with the dominance and the etc. So try to get it at a little bit higher level, and then for the nurses and for the pharmacists and for the social workers, etc., that they have their own networks as well.
That's really helpful. Thank you. That. Okay, so can we just say thanks to all our presenters today? As you can imagine, it was quite daunting to come into the first session to this massive auditorium. I think they did a fantastic job, so well done all. And I think we opened some good discussions for future discussions as well. So we have trust, we have patient-centric care, we have organisation, we have the interaction between managers and clinicians, and hopefully the next 3 days we'll have more time to debate those. So thank you all, enjoy your coffee, enjoy the rest of your day. Thank you.